Effective renal plasma flow, or ERPF, is the amount of plasma flowing through the kidneys per unit time. It's estimated using para-amino hippuric acid clearance. Now, PAH is both filtered and actively secreted in the proximal tubule. Because almost all of the PAH that enters the kidney through the renal artery will be excreted, we know that the PAH concentration in the renal veins will be nearly zero. Therefore, knowing the clearance of PAH gives us a good estimate of the total plasma flowing through the kidneys, because all of the plasma will be cleared of all of its PAH by the time it leaves the kidneys. ERPF underestimates the renal plasma flow by about 10%, because PAH clearance is not 100% perfect. Now, renal blood flow can be calculated by dividing the renal plasma flow by 1 minus the hematocrit. And the 1 minus the hematocrit is the percentage of volume flowing through the kidneys that is plasma. Basically, the percentage of plasma. Therefore, the renal blood flow, which is RPF divided by the percent that's plasma, gives us a measure of total blood flow, including both plasma and cell mass that's flowing through the kidneys. So here's a question related to renal blood flow that will be useful for you to remember. How much of the resting cardiac output do the kidneys receive? The kidneys receive about 25%. 25% of the cardiac output. And that's equal to 1.2 liters per minute. Now let's talk about filtration and filtration fraction. Filtration fraction is the fraction of plasma going through the kidneys, so through those arteries, and then eventually into the arterioles, and it's the fraction of that plasma that gets filtered, meaning it passes from the glomerulus into Bowman space. And that is called the filtration fraction. So it's calculated by dividing the GFR by the RPF. And it's normally about 20%. But it can be altered with natural hormones or drugs. For example, prostaglandins they dilate the afferent arteriole, which increases the renal plasma flow as well as the GFR, so the filtration fraction remains constant. But on the other hand, angiotensin II preferentially constricts the efferent arteriole, which, what will that do to renal plasma flow? It will lead to a decrease in RPF. But that also causes an increase in GFR, because now the pressure in the glomerular capillaries will have increased. So this will lead to an increase in the filtration fraction. Now let's continue our studies of filtration fraction by working through some changes in glomerular dynamics. To understand these changes, you'll have to know how blood flow through the arterioles affects filtration through the glomerulus. Constriction of the afferent arteriole is going to do what to renal plasma flow? It's going to decrease it. And what will that do to GFR? It will also decrease. And since both GFR and RPF have decreased, we know that filtration fraction will have no change. How about constriction of the efferent arteriole? So here we know that RPF is going to go down, but GFR is going to go up because the pressure inside the glomerular capillaries is going to increase. And this will lead to an increase in filtration fraction. Now, how about an increase in plasma protein concentration? So, if the plasma protein concentration increases, that's not going to have any effect on renal plasma flow, but it will have an effect on GFR, and it's going to decrease GFR. Now, why is that? The reason is because it's going to increase the oncotic pressure inside the glomerular capillaries. And this is going to decrease the driving force of the plasma to be pushed into Bowman's capsule. And so therefore we'll have a decrease in filtration fraction. Now what about a decrease in plasma protein concentration? Again, no effect on renal plasma flow, but this time we'll get an increase in GFR due to decreased oncotic pressure, and this will lead to an increased filtration fraction. And lastly, how about constriction of the ureter? Now, this is not going to have an effect on RPF, but what about GFR? It's going to decrease GFR because urine will not be able to flow from the kidneys to the bladder. Therefore, you'll get this back pressure building up and filtration fraction will decrease. Now let's try some sample questions. In a patient suffering from protein malnutrition, would you expect GFR to be higher or lower than normal? The answer is higher. Someone suffering from protein malnutrition would have decreased serum albumin, since they wouldn't be able to make enough protein. With that lower plasma protein concentration, the oncotic pressure keeping fluid inside the glomerulus is going to be decreased. So the GFR is going to be higher. One more question. Will the filtration fraction of a patient in the early stages of shock be higher or lower compared to a normal filtration fraction? The answer is higher. Now this is a tough one. When people are in shock, they aren't getting enough blood to their vital organs. In the kidneys, this means that RPF will be decreased. The body responds, though, by selectively vasodilating the afferent arteriole while vasoconstricting the efferent arteriole. And this has the effect of increasing the net hydrostatic pressure gradient, which in turn raises GFR. So, since RPF is decreased, but GFR is increased, the filtration fraction is going to be higher than normal in a patient with shock. So look out for these types of questions on your exam because the USMLE likes for you to think through multiple steps, but don't stress out if you haven't studied what happens during shock yet and didn't know the answer. To understand reabsorption and secretion rates, we have to compare how much of a substance is filtered versus how much of it is excreted. The filtered amount equals the GFR times the plasma concentration, and the excreted amount equals the urine flow rate V times the urine concentration. Now, if the filtered amount is greater than the excreted amount, then we know that there is reabsorption of a substance occurring. And if the filtered amount is less than the excreted amount, we know that there is secretion occurring. Now let's look at the clearance of some different substances through the nephron. Normally, glucose is freely filtered by the glomerulus. So you see it here going from the glomerulus to the Bowman's capsule. But normally, it gets completely reabsorbed in the proximal tubule through co-transport with sodium. Sodium co-transport. However, if the plasma concentration of glucose gets high enough, the glucose co-transporter becomes saturated and can no longer reabsorb all of the glucose, and some of it remains in the urine. This is a key problem with what disease discussed during the endocrinology section? Diabetes mellitus. The elevated plasma levels of glucose eventually lead to increased levels of glucose in the urine, which causes an increased amount of fluid in the urine and increased urination. This is actually one of the hallmarks of diabetes. The second important substance that must be reabsorbed is amino acids. Normally, these are small enough to be freely filtered through the glomerulus, but then they are completely reabsorbed by co-transport with sodium. There really shouldn't ever be amino acids detected in the urine, and if there are, it's a sign there might be some genetic deficiency in amino acid reabsorption. If you remember from biochemistry, Hartnup's disease is the result of a deficiency in a neutral amino acid transporter. This leads to an inability to reabsorb which amino acid? The answer is tryptophan. And since tryptophan is a precursor for niacin, this results in pellagra. So on the exam, a patient may present with the symptoms of pellagra like red skin lesions, diarrhea, and dementia, and a helpful test to diagnose the patient would actually be to check the urine for tryptophan. Alright, flash quiz. What is the formula for estimating renal blood flow if renal plasma flow is known? Alright, that's an easy one. RBF equals RPF divided by 1 minus the hematocrit. And normally, RBF is double the RPF. So that's a good thing to keep in mind.